Hello, and welcome to our listeners around the world. You're listening to JAMAevidence, our podcast series based on core issues in evidence-based medicine. Today, we're discussing the use of instrumental variables and heterogeneous treatment effects. I'm your host, Dr. Roger Lewis, Senior Statistical Editor for JAMA and editor of the JAMA Guide to Statistics and Methods series. I'm here with Professor Edward Norton. Dr. Norton, could you go ahead and tell our listeners a little bit about yourself?
Yes, thank you for having me. I'm Edward Norton. I'm an economist and the United Healthcare Professor at the University of Michigan in both the School of Public Health and in the Department of Economics. My research in economics generally involves statistical methods and causal inference, as well as an interest in long-term care and insurance and pay for performance.
Well, thank you so much for joining us. In the article that you wrote for JAMA, you talk about the use of instrumental variables in order to understand different types of treatment effects or different degrees of benefit that patients might receive, and specifically to do so using observational data. So I'd like in our discussion today to talk separately about what an instrumental variable is, and then get into this question of different treatment effects experienced by different patients. So let's start at the beginning. What is an instrumental variable, and what does it allow us to do that we couldn't otherwise do with observational data?
Sure. I like to compare instrumental variables with a randomized controlled trial. Often, randomized controlled trials are not actually possible to do. And so we look for natural experiments sort of in the wild with everyday data. And an instrumental variable is something that actually provides some randomization for some of the observations, although it is not the same as a pure randomized controlled trial. So let me give you an example of how this imperfect randomization works. Many people get kidney stones and they will go to the emergency department and ask for treatment. And the two most common treatments for kidney stones are either a medical treatment that tries to break up the kidney stone or surgery. It turns out that if you go to the emergency department complaining of pain from kidney stones early in the week, like a Monday, Tuesday, or Wednesday, that you're much more likely to be told, well, we'll do surgery tomorrow morning and you get the surgical treatment. But if you go at the end of the week or over the weekend, you're much more likely to be told, let's try the medical treatment first. And then if by Monday you're still having pain, then we'll go to surgery. So the decision for treatment turns out to depend a lot on which day of the week you show up. And people get kidney stones randomly throughout the week. So this day of the week phenomenon is the instrument. It changes the probability of which treatment you get, but it's not 0% versus 100%. There's still people at the beginning of the week who get medical treatment. There's some people over the weekend who'll get surgery, but it changes the probability to be sort of an impure experiment. And so we can compare those who show up at the emergency department early in the week and have a higher probability of surgical treatment to those who show up at the end of the week and have a higher probability of medical treatment, and just look at the average outcomes for those two groups. And then we adjust for the fact that the probability of surgical treatment is different for those two groups, not 0 or 100%, but something in between.
So at a randomized clinical trial, there's a very high chance that each participant receives the therapy to which they were assigned. But with an instrumental variable, it's just adjusting the percentage or affecting the percentage of getting one treatment over another. Is that fair?
That's right. And sometimes that percentage can be fairly small, only a few percentage points difference, which is why instrumental variables often require very large sample sizes to really be able to tease out the difference between the treatment and control groups.
So building on your example a little bit,
Mhm.
there might be some patients who, for example, based on prior experience with one treatment or another, insist on getting a therapy, regardless of what day of the week it is. Or there may be other factors that make it so their treatment choice or the treatment they received wouldn't possibly be affected by the day of the week. So how does the instrumental variable analysis adjust or account for the fact that some participants' treatments are affected by the instrumental variable and some aren't?
So one way to think about it is who is this experiment really about? And we tend to call them either marginal patients or compliers. Compliers meaning they are affected by the instrument. In this example, which day of the week they go to the emergency department. So let me give another example. Suppose you wanted to look at the effect of a drug on having a heart attack. And perhaps you do this experiment, but you do it for very young, healthy people who have almost no chance of having a heart attack, but you do the experiment anyway. You do the experiment for this very healthy group, you're going to find a very tiny, if any, effect at all. Or you could do it on an older, sicker population with high blood pressure and other comorbidities, in which case the drug is very likely to have a big statistical effect, preventing the heart attack. In the same way, whichever instrument you use, you end up looking at a different population. So, for the example of kidney stones, the compliers or the marginal patients are the ones who they really could have either treatment. They could have the medical treatment, they could have the surgical treatment. And just because the fact they showed up on a Tuesday or a Friday night, they're going to get one or the other. They could go either way. As you said, there are other patients for whom for clinical reasons or prior experience, they definitely want to get one particular kind of treatment. So, whenever you look at an instrumental variable analysis, you want to think, who are the compliers? Who are the people who are affected by the instrument? Who are the people that, if the instrument is one value or a different value, they're going to either get the treatment or not get the treatment? And then think about, is that an interesting population or maybe it's not? For the people who are not affected by the instrumental variable, we don't learn anything about how treatment affects their outcomes.
So, what you're saying is that the instrumental variable analysis really only gives us information regarding the treatment effect for that group of patients whose treatment is affected by the instrument. Is that fair?
That's exactly right. In the same way that for any randomized controlled trial, you want to look and see who are the patients who actually participate in the trial. Are they men only? Is it older folks? Is it people with diabetes? In the same way, you want to look at who is affected by this randomization by the instrumental variable. That is the population that we learn something about.
So, once we use an instrumental variable analysis to understand the average effect of a treatment, how do we go about sorting out whether or not some of the patients receive greater or lesser benefit than that average?
We can take the data set that we have and look at different subpopulations and see which subpopulation has a really strong effect of this instrumental variable and which has a weaker effect. So we can, for example, look and see whether older or younger patients are affected more by the instrument, or whether patients with certain comorbidities are more or less affected. So, going back to the kidney stone example, we could divide the population by age group and investigate statistically whether this instrumental variable of, are you more likely to get surgical or medical treatment, is stronger by day of the week if you're older or if you're younger. Or we could do that again by comorbidity or other observed characteristics. And that way we can see, for are there different subpopulations that respond more to this randomization in the wild of which day of the week you happen to get a kidney stone.
Now, in your article, you use a specific example to illustrate the use of an instrumental variable analysis in this way. Tell us a little bit about that.
Yes. So the article that we talk about in our article, a published paper by Rachel Werner and colleagues, looked at the effect of home health care versus nursing home care for patients who are receiving post acute care. And they find that home health care seems to reduce costs, but is associated with higher hospital readmissions. So, in general, what they're finding with their instrumental variable analysis is that there is an effect of having home health care versus nursing home care, after being discharged from a hospital. But that doesn't answer the question of which types of patients are really the ones who are most affected by their instrument. I haven't told you yet what their instrument is. In their case, their instrumental variable is living closer to a nursing home or living closer to a home health agency. So here they use the fact that people, when they make housing choices, don't typically make housing choices about, are you living right next to a nursing home or not? So the experiment here is, imagine two people who go to the hospital, say they've both broken their hip, they recover, they need to be discharged from the hospital. One of those two people happens to live near a nursing home, the other happens to live next to a home health agency. Not surprisingly, if you happen to live next to a nursing home, you're much more likely to go to a nursing home for post acute care. If you happen to live near a home health agency, you're much more likely to get that. So, at the high level, they're looking at patients who are affected by where they live in terms of what type of post acute care treatment they get. But that doesn't answer the question of, like, who are these people? Are they older? Are they younger? Um, are they dual eligibles with both Medicaid and Medicare? Are they of a particular racial or ethnic group? And so that's the second part of what they do in their analysis. So the first part, again, is they look at the effect of living close to or far away from a nursing home or home health agency on the probability of that treatment. And then they try and characterize who are the people who are more likely to receive those treatments. And what they found were those who were getting home health care tended to be younger, more likely to be Black or Hispanic. They were more likely to be enrolled in both Medicaid and Medicare, and to be enrolled in a Medicare Advantage plan. So that gives a little better understanding of what that set of marginal patients or compliers are relative to the general population that they're looking at.
So, in the study that you used as an illustration of the technique, they found that patients who received post acute care, home health care, incurred fewer costs, but at the same time had a greater chance of requiring rehospitalization. How did those effects differ across the patient population?
So those effects were stronger for patients who were younger and were more likely to be enrolled in both Medicaid and Medicare, or dually eligible, or more likely to be enrolled in a Medicare Advantage plan. So that is, these outcomes are heterogeneous across different kinds of populations. The younger and the dual eligibles are more likely to have these effects of being more likely to be readmitted to the hospital if they go to home health care following hospital treatment. But overall, they're actually have lower costs to Medicare.
So, if one used, say, a different instrumental variable, you mentioned earlier that each instrumental variable focuses on or allows us to learn from the population that responds to that instrument. So, would we learn about a different population and would we get the same or a different answer?
We might very well get a different answer. So, for example, let's say we looked at people who have employer sponsored health insurance, and there are often a lot of differences in the specifics of the employer sponsored health insurance plans. And maybe some of those plans financially encourage people to get home health care, and some encourage people to get uh, go to a skilled nursing facility for post acute care. Then we would have a different form of randomization. Just which type of health insurance do you have would steer people one way or the other. But because it's employer sponsored health insurance, that would be a much younger population on average than looking at the Medicare patients, as Werner and colleagues did in their study. So we would learn something about home health versus skilled nursing facility care, but for a much younger population. So different instruments can pick up different margins. There's a famous paper that looked at the labor force participation of women who have children, and the randomization or instrumental variable had to do with whether or not couples had a third child after already having two. And the instrument here was whether or not the first two children born were both girls, both boys, or one of each. Turns out that couples who have both boys or both girls are much more likely to have a third child, about 6 percentage points more likely to have a third child than those who randomly get one of each. And so in that case, the instrument is the gender mix of the first two kids. And we're looking at the labor force participation margin, not of all women, but of women who already have two kids and may or may not have a third. So it's a very specific subpopulation.
So in each case, the instrument that you chose implies a specific population whose care is influenced by that instrument, and then you get an answer about that responding population.
Exactly.
So, Professor Norton, what do you think are the key takeaways from your article for our listeners?
First of all, that as wonderful as randomized controlled trials are, they're not always possible for ethical or practical reasons. So sometimes we want to look for natural experiments where we can try and find variation in our data that, while it's not a perfect, pure randomized controlled trial, still gives us some variation in the probability of having treatment, at least for some groups. So that way we can use an instrumental variable. It provides some randomization. And if we have large enough sample size, we can tease out what the causal effects are of the treatment. We also want to recognize that these instrumental variables may only influence some part of the population, not everybody. So first we want to understand who the natural experiment applies to. And those are the folks for whom the natural experiment applies. And those are the compliers or the marginal patients. If we use different instrumental variables or different natural experiments, we may get different answers because the experiment will apply to different people. Just as we can run an RCT for one subpopulation or a different one, but also for instrumental variables, every instrument will have its own set of compliers for whom the result applies.
I'm Roger Lewis, and I've been speaking with Professor Edward Norton about the use of instrumental variable analysis and heterogeneous treatment effects. You can find a link to their article in this episode's description. This episode was produced by Daniel Morrow and Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at JAMAnetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.